Hello everyone, I'm Dr. Darsha.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Our guest today is Dr. Alexander Hajduczok, and before I introduce him as the doctor he's known to be, I want to primarily introduce him as a healthcare hero, a friend, and someone who is just a truly remarkable human being. You see, Alex is Ukrainian, and he grew up here in the States, but he has very strong ties to his culture and to his people across the seas in Eastern Europe. Now, recently, he traveled to the Polish-Ukrainian border to provide medical aid to the refugees fleeing the country. He also set up a GoFundMe page that has raised more than $18,000 to provide medical aid. If you want to support this mission and you want to check out Alex's story, I will provide links in the show notes that you can check out. Now, Dr. Alex Hajduczok is the doctor. He is a first-year cardiology fellow at Thomas Jefferson University Hospital in Philadelphia. He completed his internal medicine training at Penn State Hershey, which is where I did, and went to medical school at University of Rochester School of Medicine and Dentistry in Rochester, New York. He is interested in a career as an academic cardiologist specializing in advanced heart failure and transplant. His main research interests include remote monitoring for heart failure, hemodynamics, and cardiogenic shock. He started using Whoop in 2017 to optimize CrossFit training and has been a level 1 certified CrossFit trainer since 2016. Alex leads multiple clinical trials with wearables and uses device-measured objective data in his own life to improve performance. Now, our discussion with Alex spans everything cardiology, from his long journey into the field and how he got really interested in using wearables technology and now using Whoop, not only for patients in the hospital, but also us residents in terms of burnout and wellness. All right, without further ado, let's dive deep into this conversation with my friend and healthcare hero, Dr. Alex Hajduczok. Hey, my man Alex, here with us on Medicine Redefined. What's going on, man? How you been?
Good. It's been a while. It's been I guess like a year or so since I've been in Hershey, but I feel like towards the end of the pandemic, no one saw each other, or not the end of the pandemic, but the end of my time in Hershey.
Yeah, that's right. I mean, I was with you. So for context for the listeners, right, Alex is currently a Cards fellow at Jefferson, but you did your internal medicine residency at Penn State Hershey, which is where I am right now. And so when I was an intern last year, Alex was a senior. And I think we had two teams that we were on together, which were pretty fun. So how's Philly treating you, man? You're back in my hometown. You're originally from New York. So how's Philly?
Oh, yeah. Philly is great. I'm right in Center City. Like you said, first year cardiology fellow here at Thomas Jefferson. And I did my residency at Penn State Hershey with you there. And I did med school and college and med school, both at the University of Rochester up in New York. And I'm from Buffalo initially. So, kind of moving my way down the East Coast here. Nice to be in a big city. I'm right in Center City, like I said, like a block away from the hospital. So that's very useful from a cardiology perspective, because we're quite busy.
Dude, that's the best area of Philly, man. Midtown. Have you been to Fat Salmon yet? Is the real question of this whole episode.
I don't think so, but I'll add that one to the list.
8th and Walnut. The best sushi. It's a sushi restaurant.
What is that?
It's freaking amazing.
You know what? I think I have
it's like a
been
cool
there.
vibe with like purple lights, blue lights in there. It's pretty small, but it's amazing. Yeah.
Actually, every sushi place that I've been to around here has been like phenomenal.
Yeah, you're
a little bit better of a selection than her.
Dude, the food's terrible here. It's pretty bad. Cool, man. Well, why don't you tell our listeners a little bit about who you are and kind of your journey in terms of how you kind of chose cardiology?
It's a great question. Oh man, my journey is kind of not traditional, even though I thought it was, but had some pivots along the way. So like I said, I grew up in Buffalo. I went to college at the University of Rochester. I was always interested in medicine because of my interest in physiology, from like AP Bio in high school. And I went to college, majored in biochemistry, double majored in economics, actually. And then I like dropped the econ major second semester senior year. I was like one class away from finishing it, but I didn't want to wait, kind of, I wanted more free time basically. And so majored in biochem, and I did a bunch of research
Mhm.
in college, more from a structural biology standpoint, basic biochemistry. I spent a summer in Germany doing X-ray crystallography and NMR on a membrane protein. Came back to Rochester and worked in a lab studying yeast G protein coupled receptors, and all of it was kind of under the like my interest in signal transduction, because that was heavily implicated in clinical medicine, specifically like beta adrenergic signaling, which is key in heart function and vascular tone. Obviously, beta blockers work on the beta adrenergic receptor, and I was always interested in cardiovascular physiology the most, because it really like a structure begets function. You have structural heart failure, and then that leads to clinical um, sequela. And so I kind of had that parallel, both from a GPCR standpoint, which is structural biology. And so I was actually in the MD PhD program at the University of Rochester. I did the first 2 years in the lab, or sorry, first 2 years in med school. Then I moved into the lab for a couple of years, and unfortunately, my boss moved, and it was just going to be a
Mhm.
lot more years in the lab to finish the PhD. And I decided that I still had a lot of medical training left to go. Still had 2 years of med school and residency and fellowship and beyond. So it's like, okay, we will pivot a little bit here. And so I spent 7 years in med school at the University of Rochester. 3 were full time in the lab. We did some interesting work, but I went into third year being like, oh, I don't remember anything. Like, I don't remember what a cholecystectomy is. I had to look these things up. Everyone's coming off of step one, like just absolutely just like they know everything, and I was like, I don't remember. I know some of these words. And I started on cardiac surgery actually, which was good because no one really has a lot of experience in the OR, so it was kind of like a clean slate, or equal playing field. And I was interested in cardiology, so that was probably the one thing that I did know. And then I moved on to like surgical oncology, and I was absolutely lost. Doing like Whipples for 12 hours, and so my first like surgery rotation, every case was 12 hours long, like 8 to 12 hours long or whatever. And I didn't even realize that like that I did like a week on like just general and doing lap choles, that like you can do like 4 or 5 cases in a morning. I was like, oh, okay, that's kind of neat. Anyways, I went into like my medicine rotation, and I was like, oh my god, this is so hard. Like, how do people know all this stuff? These people have all these complex things. And I still remember like, so this was in like 2015, 2016, or 2017, and um, sacubitril valsartan was just kind of big on the scene, and Paradigm HF was published in 2014, and I remember being like, oh, there's like this new heart failure, but this is kind of interesting. And so I always just found the mechanism of activation interesting for a lot of these. Again, beta blockers and ACE inhibitors, and then ARNIs. And so I was like, let me file that in the back of my mind. I basically like barely passed like all of my rotations in med school, because I was working hard, but I just like didn't have like the aptitude, because I was out of the game for 3 full years. And then third or fourth year, I did like a SICU rotation, and I feel like I started to get my feet under me, just because you're like so ingrained in everything, and the patients are really complex, but you're just like right in front of them, and you have like one or two of them, so it's like, okay, maybe I like can do this and stuff like that. And so applied internal medicine and matched at Penn State Hershey. And at that point, like the goal was to do cardiology, and that was just solidified throughout medical school. Even when I went back into third year, I was like, the card stuff was always like was gravitating to it. I actually I did a cardiac anesthesia
Hmm.
rotation. That was really neat. You see a little bit more of the hemodynamics in real time during the CT surgery cases. You're thinking more about pressors. You're thinking more about invasive monitoring, cardiopulmonary bypass, TEs in real time for either valve replacements or really anything. And so I was like, wow, this is neat. Like hemodynamics are really cool, but like I don't understand any of it. Like maybe eventually like I'll understand it. Who knows? And so I went to Penn State and I started. I can't remember, like in clinic or whatever. And early in the fall, I had my cardiology rotation, and I was like, "Oh man, this is so cool! Like acute cardiology at this rapid pace. People are coming in with heart attacks, and you're you're helping them and you're fixing them up and you're getting them out, and or arrhythmia management, which like EP is still kind of a black box for me. But and then the heart failure service, the advanced heart failure. I was like, wow, these patients are so sick and they're always coming in to the hospital, and I was just fascinated by the pathophysiology really of chronic heart failure, and this was back to like my initial interest in GPCRs, because essentially what happens is you have chronic desensitization of the receptors from the cell membrane. You have kind of beta arrestin pathways that are activated. They pull the receptor off the cell membrane, and then it is not sensitive to the next stimuli of adrenaline or circulating hormones like epinephrine, norepinephrine. And so that's why beta blockers work in principle. Is what they do is they block the beta receptor and as an antagonist so that you don't have activation. And because of that, they stay at the cell surface. And then when you actually need the stimuli, when you need that enhanced contractility, that inotropy, the receptor still there. So that's why it's essentially like a heart failure treatment. And so I was like, wow, this is so cool. This is what I used to work on in the lab. Like I used to do biochemical reconstitution assays, radioactive binding. We purified membranes from insect cells and whatnot, and did all these like neat experiments. And now I'm seeing like how that works firsthand with treating these patients. I was like, this is basically like the bench to bedside model. Maybe not from a research standpoint, but from a clinical standpoint, because I had seen all of it. And I was still interested in research, but I was like, I can't split myself and do bench research. Also, I really like GPCRs, but there really wasn't a ton going on at Hershey. And so I was like, okay, like what else is there? And I got hooked up pretty early on with John Boehmer, who's one of the advanced heart failure specialists at Penn State. And he's done a lot with remote monitoring. And both specifically non-invasive remote monitoring, algorithm development, predictive of heart failure, hospitalization, worsening heart failure, and improvement in outcomes. And so we got hooked up actually through Amy DeWaters, who was one of the assistant program directors at the time. She was like, yeah, this would be good for you because a lot of it is very science heavy and mathematical, and I think that you'd be a good fit. And basically from there, we like took off doing a bunch of stuff. Started initially doing heart sound research, which is actually still ongoing. Now part of like larger clinical trials for that, using a non-invasive vest that measures EKG, heart sound, thoracic impedance, positions, nocturnal respiratory rate. We're specifically looking at the S3 as a marker of heart failure. Essentially what happens is you have early diastole, so right after S2, you have filling. And if that blood comes through the mitral valve and hits the ventricular wall, you'll have a low-pitched rumble, which is essentially, or murmur, that is S3. And so it's been shown in years of data back to the 80s that S3 magnitude auscultated by a clinician correlates with poor outcomes in acute decompensated heart failure and chronic heart failure. But now we had the opportunity to measure this in a more objective way. And so basically using measuring it in the inaudible range, using a very sensitive microphone, and then converting that into amplitude measures, normalizing it against the other heart sounds so that you're not just measuring like how good you are at measuring the heart sound in general. You're kind of getting into the fact that it's a pathophysiologic marker. And what we're doing there is basically correlating that to outcomes, people that are more likely to get rehospitalized, but also looking at parameters and whatnot. But anyways, so
you're deep into this shit, man. Damn.
This is how I got started in remote monitoring, because I was fascinated with a lot of this stuff. And so actually Dr. Bamer and I were sitting in his office one day, and he had this large clinical trial with this company called Nanoware. And he's like, we were talking about just people being non-compliant because they have to wear a vest for like 12 hours overnight and measure these heart sounds. And I was like, like, I have something actually that may be improved with compliance. Maybe you don't get all of the data, but you have some of these interesting parameters like nocturnal respiratory rate, resting heart rate variability, and then sleep parameters, and that being Whoop, which I have right here. And so that basically like spurred. We actually have like a feasibility trial going on with heart failure patients and Whoop, and some interesting data basically showing changes prior to rehospitalizations for a lot of these folks. And so really excited to eventually explore that deeper. But this was all kind of set in motion early on, and this is where I know you're familiar with the stuff that we did in with resident wellness,
Right.
And really like I know we'll talk about that a little bit more, but that was really my journey of going, being interested in medicine, then kind of like having this flair for research, but just kind of finding my way. I was always like interested in things, but really just trying to figure out how do you put that in the big picture, and what you can kind of do with that. And my point is like I think that a lot of this is really neat and can make a big impact, but it's not the easiest thing to do. So it just takes a lot of elbow grease. But I think that we're starting to figure out ways to help that treat patients. Actually, FDA gave it extended approval for CardioMEMS, which is invasive PA pressure monitoring in heart failure patients, expanding that to class 2 heart failure patients based off of the results from the GUIDE HF trial, which was published in the Lancet earlier this year. And they already had approval based off of Champion trial, which was published in 2017. And that was just in a more narrow heart failure patient population, class 3 heart failure with a prior hospitalization. So anyways, yeah, that's kind of my journey. A lot of nerdy stuff, a lot of remote monitoring, but a lot of excitement on my end, if you can't tell.
Yeah, no, definitely, dude. It pops out of the screen. And what I really appreciate is having these conversations with the folks. And when we ask a question about their journey, a lot of times we hear a personal story, right? The reason why, like for me, right, for going to sports medicine, Darsha is somewhat similar in the sense why we're going to something musculoskeletal medicine related, is we have an athletic background, we have a fitness background, you've experienced some injury, some dysfunction, which you can with cardiovascular disease as well. But a lot of what you're talking about is just geeking out on the science of it, right? The physiology, right? From the basic mechanistic standpoint all the way to the clinical aspect of it. I'm wondering though, from a personal standpoint, with cardiovascular disease being, the number one killer in the developed world, and just every single person essentially is touched by the morbidity aspect of it. Did you have a close one, loved one who was affected with something like heart failure? Like, why is it? I know you mentioned the physiology of heart failure is more fascinating than anything else, but did you have that aspect of it too that fed into the personal story of basically adding another 3 years onto your 7 years that you've already did, like, plus 3 years of residency?
So I was pretty fortunate to not have anybody in my family die of heart disease, either early coronary disease or heart failure and things like that. Actually, is more unfortunate. But when I was in my cardiac surgery rotation as a third year, my aunt, who we were really close, she was my godmother. She got diagnosed with with a GBM, glioblastoma multiforme, and actually basically quickly decompensated, had it removed, but there was like an intra bleed, and so she basically had a stroke, and was trying to rehab from that, but never made it out of the hospital. And so that was very unfortunate. But you kind of see, from the patient and from the family member of the patient perspective, like how difficult it can be to lose a loved one. And I think that is the same throughout, whether the cause is heart failure or coronary disease or stroke or cancer and things like that. So I think having that empathy, being on the other side of the ball, it's obviously, very unfortunate. And yeah, so I definitely have that side of things. And so I know that a lot of other people have moving stories, and what gets you into medicine and things like that. And I think that that's what makes this career path just really beautiful in a sense, is that so many people have phenomenal stories of what motivates them, and they're so different. If you talk to some people, it's like, oh, my mom was a doctor and she did this and that, and I was inspired from an early age, and it's just like so cool to hear all of that. And so I'm happy to be a part of that cohort of people that get to take care of other people for a living.
Yeah. No, I certainly agree. What I'll tell you is just hearing the passion in your voice when you describe, your research from the PhD side and all the way to the clinical side. It's almost refreshing for me, right? I think, I have the sense that when somebody comes in with that personal story, that you can empathize with the patient, right? So, for instance, you give the anecdote of GBM. Let's say it's somebody you're taking care of, all of a sudden somebody who has brain tumor, right? Which Darsh and I often do in our specialty, because we're seeing folks in the inpatient rehab side. And if you're somebody who has been through that trauma personally, it might make it extremely challenging to care for that patient. Or on the flip side, the level of empathy, the connection that you have at a deeper level might make the experience that much better. It could go either way.
Yeah.
I'm wondering though, do you think that, again, you said you've been fortunate enough that you haven't had that we'll call it adversity or experience. Do you think that helps, or does it make it more challenging for you to care for your patients?
I think a little of both. I never wish that on anybody. But like you said, I mean, sometimes you see that loved one or family member in some of your patients, and I think that you're already given 100%, 110%. Maybe you just kind of spend just a little bit more time with them at the end of the day, kind of just talking from a realistic sense. You're not thinking about writing notes and putting in orders, and you're really just kind of taking the person in front of you at face value, and saying that they're a human being, and we're here to help. And I feel like that, it just makes them so much more appreciative, just kind of sitting down with them, maybe instead of standing. And that personal touch, just putting your hand on their arm or on their leg, and just knowing that you're there for them, because I think we've all been there with alongside people that are in their final days or hours. And that was even more so highlighted during COVID, especially with some of these folks passing, and they couldn't even be around their loved ones. And so, you become that person. And I think that for a lot of us in residency, like, those experiences are never going to leave us, because that was, unprecedented. I mean, that's really never happened before, ever, calling people and saying, I'm sorry, it's hospital policy, we can't let you in.
Yeah.
And, or, whether it's FaceTiming with them, but it's still not the same. And you're just kind of, I remember being at the VA and being like, I don't like want to go home and leave this person here. They're all alone, and you can just see like the pain in their face, and you're talking with the family members, and you hear the pain, from them, and you're like, I don't have a solution. So, yeah, that was a little bit of a segue regarding COVID, but I think that all of these things impact us, without a doubt.
Yeah. And as you alluded to earlier, one of the things that this initiative that you guys had over at Penn State Hershey last year is the resident wellness thing, which is kind of what you're touching on. But I want to come back to that a little bit later. Before the bulk of this conversation, the reason why you're here is because you are a champion for basically Whoop, but a lot of this wearable technology, right? Particularly focusing on the cardiovascular system. That's your specialty. And I think Whoop is largely marketed as a consumer variable for fitness, right? And for wellness, essentially. It's safe to assume that you're a fitness junkie, you're an exercise enthusiast, just like we are, right? But your affiliate, no pun intended, is CrossFit, right? And that's what you like to do. That's how you like to train. And I'd love to hear a little bit about that side of the story. Is what attracted you towards that particular mode of exercise?
So this is a great question. The first time I heard about CrossFit was actually through my buddy who was in the military, went to West Point, and he was in Iraq, and he was like, "Oh, so we're doing some of these like high intensity workouts, and I think it's like something like this CrossFit thing, but I don't really know what that is." And I just remember being like, I was in college, and I was like, I don't know either. Like, I don't know. I just try to go to the gym and lift a little bit,
Mhm.
but I don't have time for that, or like that sounds weird. And then,
Pick things up and put them down.
right, a couple years later, playing hockey with this guy in men's league when I was in med school, and he was like, "Yeah, so I started doing CrossFit. I think you'd really like it." And I'm like, "No, I just want to go to the gym and bench and stuff like that." I go, "That's like, what is these like these swinging pull-ups and like all these like weird things? I don't want to do burpees, like blah blah blah." And then I was down in the Catskills for 4th of July weekend. We actually used to go to all of these dance camps growing up, and I was also part of that for a portion of my childhood, doing Ukrainian dancing and ballet and wearing tights and things like that. It's actually very helpful for playing hockey. But that is a little bit of an aside. And so we're down in the Catskills. It literally is like Dirty Dancing, like wood panels, blah blah blah. Like there's these big performances. Semi-professional groups from New York City would be performing, and my buddy he used to row crew at Cornell, and we were having a couple cocktails and joking around, and he was doing CrossFit, and he was like, "Yeah, one of the things is like rowing, which I obviously used to do, but it's a little bit different now doing it on the erg, like the rowing machine." And I was like, "Oh yeah, I started doing like a little bit of that at the gym, and like I'm not good at it at all. Like it's very difficult." And he's like, "Oh yeah, like what kind of numbers are you pulling?" And I don't know, it was like some abysmal things. He's like, "All right, try this. Like let's see who can row a sub 130 500-meter row first." And I was like, "Well, you'll smoke me because you rowed crew." He's like, "Well, I'm like a little bit out of the game, and I'm definitely not in like rowing shape like that." I'm like, "Okay, sounds good. I'm always up for a challenge." And it's basically just like an all-out sprint to do it under a minute and a half, and kind of like a benchmark. So I went back the next day after the weekend, and I tried it like in the morning before work. I got like a 131, and then I was like, "Oh my god, it's so close! Like you gotta go." So I went back right after work, and I hit it. I was like 129.5 or something like that. And this was in July of 2014. And I was like, "Okay, I'm sold." I got my one friend telling me this, my other friend doing that, and actually in the background, I was spending so much time at the gym and just like texting and not getting a good sweat and stuff like that. I was like, I got to do something more cardiovascular, and so I was always a fan of Rocky, and so I was like, "Oh, let me get a jump rope," because they do it in the training montages and whatnot. I was like, "Oh, I think these CrossFit people like do jump ropes." Like, so I googled like CrossFit jump rope, bought like one of those, and I started doing that before I would go like work out at the gym. And I was like, "Oh, this is pretty cool." Started to do like, what are these double unders things? Like, trying to figure that out, blah blah blah. And so like that plus like this rowing challenge, I was like, "Oh, okay, like I'll give it a shot." So I went to this gym that was nearby called Flower City CrossFit, and I walked in, and it was like they would do heavy lifting on Wednesdays, and I'm like walking into the back gym where they did like the boot camp like thing, and I go, "Hold on, like I want to like lift, like what's going on? I don't want to go do the stuff in the back." I did the stuff in the back, and they were like, "Okay, yeah, you'll be fine for like the real thing. We just need to teach you some of the movements and onboard you, and then you can start next week." Came back like a week later to do the real thing, and just got absolutely rinsed. Just like I was on the ground, like in pain. It was like a 7-minute workout. I go, I don't even know how this is possible. And it was like burpees and pull-ups and like kettlebell swings, and I was like, "Yeah, I don't know how to do these tipping pull-ups. I can't do a burpee to save my life," and I still basically am in that position. But yeah, so I started it, and like the rest was history. I started going 3 4 or 5 times a week, making time for extra mobility sessions and flexibility. I think that was actually one of the first eye openers, because I remember having like shoulder pain just from benching all the time or doing curls and whatnot. And I went and started doing CrossFit, and everyone's like, "Oh, you'll like hurt yourself." But because of the emphasis on like movement patterns and flexibility and mobility, in particular, all that pain went away. like literally, I was like, oh, it was like literally like in Mighty Ducks when he was like, oh, the pain is gone with his wrist. And so yeah, I like started the people at the gym became like a second family, and we would always be there and working out together. We would always go to at like 6 a.m. And then I would try to go back after work if I could. And yeah, it's just like so much fun. And I started coaching in 2016, so like I would coach like three classes a week, and then continue to work out, which is great. And I coached through residency in Hershey, and still have my L1, but haven't coached here because I've been a little bit more busy in fellowship.
Gotcha. Alex, I think CrossFit's awesome for that reason, right? I mean, I think the family aspect to it, right? You got that camaraderie, the accountability. And then I think a lot of people struggle on kind of mixing weightlifting and cardio kind of together, right? And getting that good sweat, like you said. I know you're kind of crazy and did Murphs, a lot of them, but before I ask you about those Murphs, I wanted to ask you about Whoop, because the first time I ever heard of Whoop was actually last year. So when did you first start wearing it, and why Whoop?
Yeah, so this is actually funny as well, because one of my buddies like comes in and he's like, yeah, I like heard about this like thing, like this wrist, like this Fitbit type thing or whatever. I go, oh, that's like sounds like interesting. Like, what does it do? Oh, it tells you your recovery score and like your strain and stuff like that. I go, oh, that's like sounds pretty cool. And around actually they did a Black Friday deal, which was at the time it was a flat fee. It was $500, but on Black Friday they did buy one get one. So me and a buddy like split it, so it was like $250 like for a one-time fee, and I got it, and I was like, oh, this is like really cool.
Mm-hmm.
And I was like, immediately I was like, oh my gosh, I do not sleep like at all. So that was like the first thing that I figured out. And then I was like, oh man, some of these metrics are cool, like both from a recovery score, which is kind of proprietary, blending in a lot of the things that a lot of the physiology from a cardiovascular standpoint, the main one being heart rate variability, but also resting heart rate, and then your sleep, including REM sleep and deep sleep. And so I was like, wow, this is neat. And this is 2017, January or December 2017. I started wearing it, and continued through med school. And then when I went to residency, I was like, oh, I didn't know it was possible to sleep less than I was, but I guess that's going on. And I got to the point where I was like halfway through is like February.
Do you have any children? Just sorry to interject. Do you have any children?
No children.
Yeah, that could change as well.
Well, I feel like I'm already like bottomed out. So
yeah. Oh, trust me. Let me tell you.
Yeah.
Sorry. Go ahead.
One of my friends tells me that she's like, you'll be great when you have kids because you're already so used to not sleeping like at all. I go, okay, well, we'll see. Maybe it'll be less than this, and then I'll be in trouble. But yeah. So we I was doing a CrossFit competition in Miami called Wadapalooza, and I was home training for it for like the week before, and I was trying to get like really granular with the data and really trying to optimize all my recovery and training. I was like, let me pull some of my data through residency just to kind of look at stuff, explore some endpoints. Like, do I sleep more on certain rotations or sleep less, or how's my heart rate variability and how does that change from rotation to rotation and whatnot, and just kind of figure out what's going on. And I had a graph that I think is actually published on some of the Whoop sites, and I basically like looked at 18 months of data. I ran some regressions to figure out like where there was correlations and whatnot. And my sleep was again brutal. Like there was a month that I slept an average of 4 hours and 40 minutes for 30 days. So that was kind of bad. And I was like, wow, this really correlates with, the rotation. You're in the NICU, you're like not sleeping at all. You're doing nights. Sometimes you're sleeping worse than, or you're like on consults in clinic and, outpatient, like you guys, and you're like sleeping like, I mean, for me, it was like still 6 hours a night, but that was like a lot for me at the time. And I was like, wow, my wellness is so good. My heart rate variability is great. Like my training is going well. And then I would like hit the ICU and it'd be like, woo. So my thought was like, I'm kind of training constantly throughout, but it seems like these changes in the metrics, particularly heart rate variability, were very contingent on like the type of rotation. And even when I controlled for the amount of duty hours, there was still differences. And so I kind of attributed that to the stress of a certain rotation.
Mm.
You can work 100 hours in the clinic versus like 100 hours in the ICU. Maybe 100 is not a good number to pick, but like a full work week in the clinic versus a full work week in the ICU, even for the same amount of hours, like you're generally a little bit more stressed in the ICU. And so my thought was like, can we capture this objectively? And because I had like my Whoop data is kind of like a starting point, did some power calculations, figured out like what it would take to measure a significant change from baseline in heart rate variability based off of that, and set up a clinical trial to do this in residence. And we had almost 40 people wear it for 12 months, and really saw some interesting stuff. Kind of working on still analyzing the final data set
Yeah.
now. But I think that's when Darsh comes in, because
That's right.
we absolutely we included the inclusion criteria was internal medicine residents only because we're
Oh
really
man,
interested in the schedules. And I was like, sorry, man, like I can't
that's
like
sad.
have you in this set, but like let's see if we can still get you on board to collect some data. And then we got him on board, and I think that was, I still remember, oh man, we got like the
Oh
same
wow, look at
thing. I
that.
have 100 reps. So the likelihood that we're wearing the same one is pretty low. But yeah, I still remember we're on that IMC rotation, and I was
Mhm.
like, yeah, man, like, let's like we got this going. Are you interested? Like, let's do it. And rest is, I guess, history, right?
Yeah, absolutely. Alex, let me ask you real quick. When you thought about using Whoop and tracking your own progress, what did you think about HRV? Like, how good of a marker did you think it was to really and truly look at your own fitness and health?
Another phenomenal question, and I think that in order to answer that properly, I'll take a step back and kind of explain what HRV is and how I think about it.
Okay.
So what HRV is heart rate variability, which if you think about it, it's your heart rate. Okay, so your RR intervals, if you're looking at it on an EKG or like a Holter monitor or something, and then it's variability. So you know people's heart rate changes over time. And when that change occurs, you can essentially measure the difference in that RR interval. And you can look at it in many different ways. You can look at standard deviation. You can look at like root mean square differences. You can actually go way, like there's a ton of literature. There's a ton of different ways. You look at low frequency, high frequency, you look at the ratio. Essentially what it is in a nutshell though, is it's the like the beat to beat variation in your RR intervals. And so that heart rate variability is essentially how your heart rate is changing to an external stimuli, or internal. Your kind of your parasympathetic and sympathetic nervous system, which is obviously under regulation of hormonal changes, stress, emotions, but also like external stimuli. Like if Tiger walked into the room right now, like probably my heart rate would jump up, and I would go run, and we'd end this Zoom call. And you have activation of the sympathetic nervous system, so your heart is going to your body's going to tell you to increase your heart rate, a fight or flight response. And the rate that heart rate changes, how responsive it is to that external stimuli, is essentially what heart rate variability is captured. So if you are well rested and well recovered and things like that, and your heart rate is sitting there, say it's like your resting heart rate is 50 or 60 beats per minute, and like boom, it'll jump up very quickly. Versus if you just came off of a 24-hour shift, which I did yesterday, and you're just kind of tired or whatever, you're really stressed out, your heart rate response is going to lag. And so your variability is going to be lower because it's basically going to be similar, variation in terms of like how many milliseconds are between your heartbeats. And so that what that heart variability is like a balance of your autonomic tone, your parasympathetic versus your sympathetic nervous system. And what that readout essentially means is like how recovered you are or how ready you are to take on additional strain. And I think that strain can be both a physical stress, training in the gym or, obviously going on a run or whatever, or mental and emotional stress. You go in and we all have stressful lives and regardless if you're in medicine or not, things are super stressful. Like look at COVID, everybody's been under the gun there. And so, you're kind of looking at your heart rate variability is like something that you want to optimize over time, both on it from in the acute setting, like day to day, but also long-term trends. And so you can look at the acute setting heart rate variability is like, okay, it's what I did the day before, the couple days before. Sensitive to like you eat a late meal, you're going to have much more parasympathetic stimulation overnight, versus like you're just really doing well with like eating clean, doing a lot of training, your heart rate variability will generally be high. But there's a lot of things that can change it. You overtrain a bunch, like it'll eventually be lower, but the overall trajectory over time is going to be higher. So what I'm getting at is you can actually use that as a marker of overall improvements in fitness. And if you look at it, I actually recently wrote about this and used some of my own data as an example. You can look at HRV trends on a month-to-month basis of averages and see if you're basically like improving your fitness, if you're staying the same, or if you're kind of like slacking a little bit. And you're like, oh, maybe I should allocate more time to diet and exercise, if you're interested. Or you can just be like, oh, I'm good, I'm glad I have the data and I know what I'm doing, but right now I'm really busy or I'm tied up with work and I can't allocate any more time. So it really allows you to guide your lifestyle decisions, guide your kind of productivity from a work standpoint, and it kind of gives you that readout of like, this is what I've done and this is what I can do with it. And so I think that it's an extremely powerful metric, and it's why it's the largest contributor to the recovery score that Whoop uses.
So, Alex, you talked about this, the difference between the R to R interval. There might be some people listening who are not familiar with what that terminology means. Do
Yes.
you mind explaining that
Of
briefly?
course. So basically, I think a lot of folks have seen a tracing, like an EKG tracing, and you kind of have like the boop, boop, boop. So what that is a QRS complex. That's a ventricular contraction. It's usually preceded by a P wave, which is the atrial contraction. But the R to R interval is essentially like the peak to peak of those beats. So it's a marker of your heart rate. It's just a positive deflection towards the EKG lead. So that's what the R interval is. And then as that changes over time, almost like an accordion, that'll be like how you measure your heart rate variability.
Yeah, and this I find this discussion to be sometimes a bit challenging, and maybe that's because I don't understand this as well as someone like you might. But the way that I kind of try to explain it to people, well, what you just did was spectacular. But at the same time, what you're talking about is that variability in order for it to be high. So we said that the R to R interval is measured in milliseconds.
Mm-hmm.
Is that correct? Right. So if somebody who has high variability, it might be so everybody, like you said, is familiar with how many times your heart beats per minute, right? So it could be 60 seconds. If you're highly trained, it could be in the 30s or whatever it might be. And so people are familiar with that concept. But for HRV, it might be like 0.9, and the next one might be 1.2, and then 1.3, and then 0.8 again. And so that's a high variability, right? Now it's a bit counterintuitive because you would think that, hey, I want it to be consistent throughout, right? But the way that I try to explain it, well, if your heart's capable of doing that and going up and down, then kind of going back to that tiger or saber tooth example, that it's much more adaptable. Is that a fair assessment?
That's exactly right. It's the ability to respond to that change. Because if not, then you're basically, your heart rate variability is going to be very low. It's just going to be stagnant no matter what happens. It's going to be the same, or low variation, or the same interval.
Gotcha. Now, so we've talked about Whoop quite a bit, right? That's the one that both of you guys are using. So something that I often see, and maybe you guys can tell me, is people talk about their strain score a lot. Now, where does that fit in? If somebody could explain what that is to me.
So strain is a it's a proprietary metric that Whoop uses. Other people or other companies and more familiar with you're trying to guide, or you're trying to describe how active you are, essentially. And well, I'll get to strain in a second, but Fitbit, for example, uses step counters, or there's a lot of step counters out there for in terms of activity monitors. And so, I think that over the years, a lot of people will talk about, oh, get reaching 10,000 steps or whatever. And I guess the question is,
Mm.
like, is that really like a useful metric? Is just like going for a walk for 10,000 steps like useful? I mean, some of us walking around the hospital, I probably hit 10,000 steps. I don't feel like I necessarily like am improving my exercise tolerance because of that. I'm just at work. Sure, it's better than being sedentary, but like, are you really going to improve your performance? Probably not. So what strain does is it analyzes your personal data, and it looks at your heart rate changes over time, and it says, okay, how high has your heart rate been compared to your personal baseline of your resting heart rate? And then that's basically like how much strain is been put on your heart. And so the way that the metric essentially works is that if you plot heart rate against time, and then you take the integral of that, so the area under the curve, that and that is the measure that goes into strain. And then what Whoop does is they plot it on a 1 to 21 scale, but it's actually on a logarithmic scale. So it's easier to go from 0 to 4 than it is to 4 to 8, than it is to 8 to 12, et cetera, et cetera. Like I've done extensive workouts, and you really basically can't even hit 21. Like 20.7 is the highest that I've gotten, and I've hit that twice when I've ran a marathon.
Sorry. Yeah. So, earlier you mentioned how different variables, particularly the autonomic nervous system, excuse me, can, manipulations or, aberrations in that can really affect your recovery score, right? And your HRV particularly. Now, I think largely what we're talking about is we know that stress, like physiological stress, pathological stress, is going to affect the nervous system. So that's why, like, if you are, if you are in a fight with your spouse, or if you've worked an ICU shift, or if you just finished a code, you lost a patient, you lost a loved one, your body's going to have similar responses. When it comes to training, though, right? So for adaptation, we also have mechanical stress, we have metabolic stress as well. Do those, the latter ones that I mentioned, in terms of things that are required for adaptation positively for training, right? For performance specifically, is what you touched on. Do those tend to affect HRV as well, or is it particularly looking at the autonomic nervous system and aberrations
No,
in that?
that's a great point. You definitely will see your HRV being affected by your training habits, and so you're kind of like, you can basically look at it like on a person to person basis. And I think that that's one of the strengths of Whoop, and essentially balance your strain to recovery to figure out what your optimal training should be. But it's not a perfect world. So sometimes you're going to be low recovered, but you're planning on hitting the gym hard. That's not the end of the world. But eventually, like over time, if you're really overreaching, and by overreaching I mean your strain is far like greater than relatively like where your recovery is, your heart rate variability is going to kind of tank because of that, like in the subsequent days. And it's just basically your body saying, like, I need help, like I need a rest day. But hitting that, like day in day out, is and watching your heart rate variability change based off of that is how certain people um guide their rest days, or like active recovery, or maybe I won't hit a double session that day. Or on the flip side, like you're really recovered, you have a high HRV, you're like, okay, today's the day I'm gonna go for like a PR on some lift or some benchmark workout, or hit a 2 a day or anything like that. But it is very responsive to your training habits. And it's hard because obviously at the same time you're under stress and things like that. So you got to weigh all of that and to really figure out what's causing that. Is that because you're stressed at work, or did you hit the workout like really hard? Um, and so you
Mm.
can actually answer that question a little bit using the Whoop journal. And so that kind of takes into account some of your lifestyle habits, like, and it's customizable based off of, like, I think there's like 111 different variables that you can say like yes, no to. Working late, eating a late meal, did I hydrate today? Did I stretch? Did I use blue light glasses? Did I use a sleep mask? And you can essentially run a unpaired T test based off of your own Whoop data to say, okay, when I say I did um, like a cold tub for recovery, in the last 90 days, based off of my recovery, how did my HRV change with everything else being a constant? And so you can actually ask that. And so, some of the other variables that it'll read out is days that I was over X amount of strain, like a high strain day. You can use that as an independent variable. And so you can start to tease out, like, is this my training that's taking my recovery, or is it like stress at work, or like some of your lifestyle changes or modification that you make, like, oh, is this helping or is this hurting? Like alcohol, if anybody's ever used Whoop, they'll be able to know that alcohol is going to just drop your recovery, drop your HRV to like the lowest levels you'll ever see. And then staying away from that, you'll be like, wow, these numbers are really good. And it's real, because alcohol is a depressant, and it's basically just going to drop that variability factor.
Yeah. To your point, man, it's why I'm wearing the blue blockers right now with the Whoop journal. I mean, it's the number one thing. It's increased my HRV by like 10% to 20%. So it's made the biggest difference in terms of my recovery. But Alex, I wanted to ask you, so HRV, we know there's some genetic component to it, right? I mean, there's some individual basis, but then there's also some component of fitness. Now, I guess I'm asking this selfishly because I'm probably in that bottom like 20, maybe even 10%. I don't even know. But like 100% recovery for me on the Whoop is probably an HRV of like 50, and I mean, I'm pretty fit, and I mean, I can run a mile under 7 minutes. I can run 100, I could sprint 100 meters in less than 12. I can lift pretty decent weight. So like, for me at 50, is that worrying, or is that something that's just genetics? And then my follow-up question to that would be, do you know, based off the wearables like Aura Ring versus Whoop, would the HRV stay the same throughout that?
So, great question. Two parts to that. So your first part of the question is essentially, is my HRV of 50 mean, like, is that bad? And the answer is no. All of your recovery scores are going to be calculated off of your personal baseline. So it'll be your change from baseline. It's why, like, for you, 50 might be very high recovery versus for someone with a baseline of 100, 50 is going to be low. And that does vary on a person-to-person basis. So you can't compare my HRV to your HRV. It's a apples to oranges comparison. What you can compare a little bit better between person to person is resting heart rate. And so that's something that um, you can kind of look at and compare, almost like level of fitness to some extent, a little bit better. But your HRV is going to be a personalized metric. HRV will decrease over time, just with aging. But then you can also increase your HRV with improvements in fitness and exercise tolerance. So, there's kind of a lot of factors that are going to go into that, and you kind of got to figure out where you are on the curve. Is it decreasing because you haven't hit the gym in 6 months, or, I mean, aging happens at the same rate for all of us, so everybody's going to have a slow decline. But if I look at my HRV from 2017 versus now, like, would I expect it to go down? Maybe, but that would only be if I said that my training has been constant throughout. But if I think that I've been getting in better shape, which I think that I have, then I would expect my HRV to be increasing from a training perspective, but maybe decreasing a little bit, like weighing a little bit down from just getting older. Um, Now, the second part of your question is, how does that compare to Oura Ring and things like that, other metrics of HRV? In short, I don't really know. I think that they've done stuff looking at both of those in comparison. I'm just not someone that would wear a ring, really, so it's never been appealing to me. But I know that stuff has been done, and also versus Garmin. Actually, one of my friends, who's a bioinformatics PhD down at Duke. She wrote a paper on basically heart rate variability and how well it's measured amongst different devices, both that are consumer grade and research grade. Pretty interesting results. The research grade is better at measuring it at rest. The consumer grades are a little bit better at measuring it with exercise, kind of as you'd expect. In terms of HRV and what readout you get, I might butcher this, but I think that Whoop uses the root mean square 50, and I think that some of the other ones may use different HRV metrics, because HRV could mean 10 different things, and this is like an electrophysiologic standpoint, and it's like how you run the statistics. So there's probably going to be differences, but they should be internally consistent, because if say you had Aura and you had Whoop, you should kind of see the same trends along both, regardless of what type of HRV they're measuring. Now, one of the reasons I like Whoop, and I can't comment on when or Ring how they run their measurements, but Whoop will essentially standardize your HRV to the last 5 minutes of your last cycle of slow wave sleep overnight. Because you look at the data, that time in slow wave sleep or deep sleep, which is a form of restorative sleep, along with REM sleep. During that time in deep sleep overnight, you are having the least amount of intrinsic stimuli, like fluxes in your sympathetic or parasympathetic nervous system. And so it's just going to give you the cleanest readout of a standardized metric that you can compare to yourself from this night to the next night to the next night. I believe that Aura probably does a similar calculation, but I just don't know the specifics of when they do it.
Yeah, dude. So you strike me obviously as a very analytical person who has an appetite for paying attention to these details, right? Clearly with your PhD background and basically everything we've been nerding out about for the last almost an hour. You mentioned that in 2017 is when first exposed to Whoop, but you've been training for a lot longer than that. What metrics were you using prior to this for recovery, and how were you allowing those to guide your recovery?
So my background going back to like high school and growing up was I played hockey and soccer. Hockey being the main sport. I actually played hockey growing up with Rob Gronkowski, and we went to high school together, and he's 1 day older than me. So that's a kind of a caveat there. But I didn't really pay attention to anything from a training perspective. Like I was just going based off of feel. And so really you're just kind of living on the edge and flying by the seat of your pants, for to drop some cliches. But yeah, no, really wasn't using anything. So I really was not, like you said, I think that I'm a little bit of an analytical person, but I basically was just going by random chance and like, oh yeah, I'll work out today. Just really going off of my schedule, I guess, which is not like, a way to optimize things. Sure, it might be like from a time management standpoint, but like, you're trying to get more granular. You're trying to figure out like, how can I unlock human performance better?
Yeah, no, I love that. So now having a deeper understanding of it, though, you probably come across maybe a lot of patients, right, who are interested in performance, and maybe they're not necessarily interested in getting all the data and everything. And also, there's a price tag to something like this, right? How do you advise them to look at some of the basics in terms of metrics, right? Is it resting heart rate first thing in the morning? Is it throughout throughout their workout? That kind of stuff. What do you suggest?
I think it's from a patient perspective, like for the people that I'm dealing with, I would say that I'm just happy if people are exercising in general. And I think that if having a wearable that gives you some biometric feedback is going to be helpful for that person, then I would recommend it. I'm not sure, how deep I would go with looking at particular data, but I think that, if you wanted to look at one easy one, resting heart rate is just, I think, the easiest to understand and track, because there's not going to be as much fluctuation on a day-to-day basis. but from a different patient population, I think more from the folks that you guys work with, and I've worked with a lot of people, kind of in coaching and CrossFit that use Whoop or use other wearables. I think that you can get a little bit more kind of in the weeds with the specifics of the data with them, and I try to kind of teach them how I think about it, and how I look at recovery, and based off of HRV and sleep, and things like that. And you're obviously trying to optimize all of them, but the question is like how. And so for some people it's that their sleep habits are poor, and maybe it's just the time in bed, or maybe it's because they watch TV, or maybe it's like the blue light blocking, or maybe it's like other techniques that may help, like using a sleep blanket or using dark nightshade curtains because they work nights. And so it really depends on the person. But I think if you have that conversation, you're like, what's the problem? Or, do you have trouble sleeping? Are you stressed at work? Do you not have enough time for things? Like, what kind of workouts do you like? And it really comes down to like, what are your goals? Some people are trying to lift a lot. Some people are going for high endurance, like capacity. Other people are doing CrossFit and they're kind of in the middle of that. So, I think that the beauty of these wearables is that you can tailor it from person to person. And it's the same for that pro athlete, it's the same data that they're collecting, but maybe they're using it a little bit different. And that's going to be the same for someone that just wants to sleep a little bit better, and have that feedback. And so I think that it's awesome to be able to, such a wide diversity of people can use the same device, just in slightly different ways.
Yeah, man, let's go into the applications now, right? Into medicine. I mean, you have a creative mind. You kind of thought about, well, let me start by saying this. I think a lot of the research in medicine, we tend to think of what can we do internally, right? Like what can we use within the hospital? Rarely do we think about how do we bring out the technologies from outside just healthcare and bring them in to see how can we collaborate and change healthcare altogether, right? So talking about currently in the present moment as well as the future, what are you starting to see wearables and their role in terms of different studies that are starting to come out?
So I think there's a lot of interesting stuff with wearables. You can use it, and I think about it in terms of buckets. So you have the kind of preventative measures, and whether that's like lifestyle prevention or exercise or whatnot, or whether it's early detection of diseases, both from a diagnostic standpoint or prognostic standpoint, or a screening standpoint. Particularly for screening, there was the Apple study with AFib, and then Fitbit did one recently. And so, and really, like the data was not very strong there. They noted they were able to detect more arrhythmias, but it really didn't make a difference in clinical outcomes. So the question bears of how important is it to measure these maybe non clinically significant changes. And I think that actually opens a larger conversation of like over screening and utilization of healthcare and whatnot.
Mm.
But also like sometimes bad outcomes. Like someone could, you detect AFib for a minute on their Apple Watch, now they're on a blood thinner, and then they come in with a GI bleed. Did that person need to be on that when they were perfectly fine at home before? Anyways, so then you can kind of use it as a prognostic tool. So that kind of gets into more of what I was speaking about with the S3 heart sounds and things like that. There's these multi-parameter studies or devices that are usually implantable. One of them is HeartLogic with Boston Scientific. Basically gives you like a score for a HeartLogic score for how likely you are to be rehospitalized and things like that. That can guide therapy with diuretics and guideline-directed medical therapy as an outpatient and whatnot. And then there's kind of the general consumer side of it, where maybe you're not looking particularly at clinical outcomes, but I think that there was like a British Medical Journal article recently with that actually correlated step count with mortality or something like that, which I thought was pretty interesting. And so all of that, that conglomerate of wearables, I think is it's one part of the digital health revolution, but I think it's a pretty large part. And in part because people can see themselves wearing it. Like it looks. I mean, I think it looks cool, but like the apps and stuff like that, we're already on our phones all the time. Like, why not allocate a little bit more time to improving your health and improving your wellness and really just improving your lifestyle in general?
Yeah. Well, the Whoop commercial with Pat was pretty awesome, man. It was pretty cool that they did that. So, but it's funny. It's funny you mentioned, like just look at patients. I think about this all the time. Ever since wearing Whoop last year, in the PM&R setting, right? I mean, we have patients who are very stable who do physical therapy, occupational therapy every single day, right? And I'll see both sides of the spectrum where it's like, oh, I didn't really get to do much. I could have done more. Or you see very motivated patients, right, that really want to get back to walking and things. You'll see the opposite side of the spectrum. They're like, I can't do physical therapy today. I'm not feeling well. Or the next day, oh, I'm too sore. And I would just love, right, to see them have a Whoop. Unfortunately, I mean, I guess it takes 3 to 4 days to get a baseline, and sometimes our patients are out by then. But I mean, even 2 weeks to a month, and just kind of seeing like, man, like, are you actually good to do PT today, right? I just think that'd be a cool thought experiment at least to do.
Yeah, or guide like the amount of
Right.
rehab that we always talk. Oh, can they go to acute rehab? Oh, can this person like tolerate
Yeah.
3 hours of rehab a day? It's kind of like a judgment call. You're like yes or no, but like what is that really rooted off of? Like you
Yeah.
spend like 10, 15 minutes with the patient, but if you had like days and weeks worth of data during an inpatient stay, and you can monitor their progression, and then you can see how that improves or gets worse with rehab. I think that's great for any injury rehabbing, but also
Mhm.
cardiac rehab, things like that.
Yeah.
Obviously, cardiovascular system.
Right.
But I think you get a great point. Like I feel like that would be like a phenomenal thing to look at with how you can guide therapies, whether it's rehab or meds and whatnot, because like all of these things are tied into your physiology.
Yeah. Josh, to your point, I will jump in and say so. That would be challenging. I mean, it'd
CMS.
be certainly cool to see. I think from a clinical perspective, the subjective portion in those settings, I think, outweighs the objective data, right? In when somebody's in the acute inpatient rehab setting, and like, okay, so historically going back, and I think folks in the performance sector, like if you have a good coach or if you even have a personal trainer or something like that, and a lot of what they'll do is if you go to them and they'll ask, hey, how are we feeling today? Are you ready to crush it or are we not? Right. So it's your readiness score subjectively on a scale of 0, I don't feel like being here at all, I can't believe I got a bed, to 10, I'm ready to just load up this and go for a PR, like
Yeah.
Alex was talking about, right? That's your subjective readiness score. So I think when it comes to the inpatient rehab aspect and the clinical aspect, I mean, and that means a lot. And I think in an era where we didn't have any of these devices, like Alex was talking about, like just I think this has been validated actually, just getting up resting heart rate, right? But also again, willingness to really get after it for in the elite
Right.
athletes particularly is a good marker overall for kind of like recovery essentially.
Right, I agree, and I think that having that data, especially for those performance athletes, just kind of gives it's not you can't just look at one number. You're taking that ensemble. There's days when my recovery is high,
Yeah.
but I feel like shit. I mean, that's just life. But I think that the overall correlation is pretty good.
Oh, cool. Awesome, Alex. I kind of want to tie this all back together, man, with the inception of Whoop and that study that you kind of brought to life in terms of wellness. Take us through some of the preliminary data. I know not all of it's kind of read, but if you are able to tell us what you're finding.
Yeah, so it's really interesting. So the initial pass through some of it, we're kind of looking at how much people are sleeping and whatnot, and there definitely seems to be like major fluctuations based off of which rotation you're on, which I think is what we expected. But it's really cool to see that data across 30 plus participants, and then the same thing with HRV and also resting heart rate and whatnot. I think what we'll end up seeing is that there's probably going to be like maybe not one variable that directly correlates with, because what we did in the study was essentially compare Whoop data to subjective assessments of wellness, burnout, and depression, and then in the setting of people are switching rotations and whatnot. So we looked at all those outcomes, and I think that what you'll see is that well, one, not everybody's the same. So there might be people that are more or less resilient to some of these changes. We actually used Angela
Or
Duckworth's
I guess you need an
resilience
attending to have.
score as one of the baseline characteristics.
Yes and
So
no.
we can
Okay.
actually answer that question.
Gotcha.
But so people are going to be different. But I think that some of the general trends, I think, will be powered to say that, okay, X, Y, and Z does seem to correlate with poor wellness or improved wellness, or like borderline depression scores, or whatnot. I mean, we've all felt it, like from an acute standpoint, but also from a chronic standpoint. And I feel like it's not really talked about a lot, but I think there's a lot of people in medical training that get down in the doldrums that
There it
are,
is.
they would score high in a PHQ-9.
Yeah.
They probably are depressed, and I think that we don't really do a good job of figuring out like what to do with that. We get wellness modules thrown at us, and it's like, you need to do this now, like all caps, like otherwise, like we're
Right.
withholding your next paycheck, or oh, here's like a party, like that'll make your 80-hour a week for the last 3 years, like go good. And they give you like a water bottle for like being like
Hey,
a
it's
COVID hero,
resident
or
it's resident
something like that.
appreciation on Friday,
You just
so
kind of,
I'll get some candy bars.
oh, there you go. Yeah, I mean, and it's tough because wellness is such a subjective thing, and my wellness might be different than someone else's wellness. Someone else just may want to go home and read a book or go on a walk with their family, whereas
Yeah.
I might want extra time to go to the gym. And you're so busy during residency, you're working a lot of hours, and I don't think that that's really something that we can change based just off of the structure of the system. Again, whole nother question about medical training that I don't really want to like tackle right now. But in the environment that we have, I do think that there are things that we can do better. One of those is potentially looking at some of these metrics and figuring out like where we're bad at it, and then, okay, well, maybe like we know the ICU is bad, maybe we can figure out like a better rotation structure to make that a little bit, so to improve that, or like scheduling people so they're not doing like ICU and then like floors.
Mhm.
And people just get burned out from that. You gotta. I mean, the 6+2 or 8+2, 4+2 models work really well with that, but maybe there are better ways to structure that. Like, not give you three hard rotations in a row. Kind of almost do like a point system, like 3, 2, 1, and you don't want any block to be greater than a certain number or whatnot. Kind of like have all this like calculated out and whatnot for some of our study parameters. But I think that would be really neat, and I think that program directors, I think, hopefully once we publish the results, I hope that they give it a serious look as a tool to actually improve wellness beyond modules and pizza parties.
So, I'm trying to dig into the why a little bit more. Was your hope when you started this project to say, hey, like, where can we? Because in order to get buy in, right, at an institutional level, you need to pitch something where you can make actionable change, right? And so, was the hope that, hey, if we can figure out how people are responding or quote unquote wellness, maybe we can formulate the rotation structure a bit better to for lack of a better word, optimize wellness? Is that kind of what the purpose was?
Yeah. Yeah. So I was the lead on everything. Based off of my data, the person that
Mm,
bought in and kind of supported it was one of our program directors, Andrew Tinsley. He's in GI, and also was on board with Whoop. He's a big golfer, and it's pretty big in the golf community. So he had heard about it. We were sitting in the ICU one day on a weekend, and I was like, "Hey, I looked at all my prelim data. I think that there's really something here to do." Was about to like scope someone with like a massive GI bleed, and we're talking about it. And we were like, yeah, like, why don't I'm just going to submit the IRB, and we'll figure this out. I think that it's certainly worth a shot, and seeing, if we can get funding and whatnot. Um, and from the statistical standpoint, one of the reasons why I was actually confident that we can ask these questions and like do the properly powered study and whatnot, was I was basically practicing analyzing my data with the whole MRF thing, which I know you mentioned
Yeah.
at the beginning, Darsh, but we didn't really get into
It's
it.
all good.
So all of that really played a role. Like my initial like pass through my data in halfway through residency, seeing that I don't sleep a lot, seeing that there's correlations, and then kind of going through and figuring out logistically how do I make this happen. I wrote a bunch of grants and got funding for a project, and then got buy-in from the department and from the program, and then just ran it by the institutional IRB, and the rest was history. That's exactly what it was. We kind of had a bunch of different ideas, and I kind of mentioned some of the scheduling changes, or like even something like, does the ICU rotation need to be a month long? I think that once you hit week 3 and 4, you're kind of like beat up. And I feel like that could easily be swapped into two-week rotations like we do the rest of ours. I mean, this is more specific for us at Hershey. And so we kind of had all these ideas. And, I feel like when we talked to the program, they bought in because, having objective data to ask and answer these questions was something that they were interested in. And I'm glad that they did, because I feel like now we have a very large data set to hopefully make improvements off of.
Awesome. Well, dude, this has been absolutely incredible. I am having a difficult time processing the fact that you just came off a 24-hour shift. Your
Well,
excitement.
I slept this afternoon, so like I mean
Okay,
yeah, no,
fair enough.
I worked until this morning.
You got a little bit more recovery in your system
Yeah.
before you jumped on here, man. I can't thank you enough. This has been so amazing and highly informative for myself. Before we let you go, I do want to know, man, and you've got this inquisitive mind, right? You're extremely knowledgeable. What's next for you, man? Whether it's in clinical aspect, whether it's, it doesn't have to be medicine, your own personal life, fitness related. What's coming up for you? What are you excited about?
Excited about a lot. I'm excited about, continuing on in fellowship, kind of like passing the halfway point here in first year, which is a little bit busier. So eventually it'll kind of lighten up. We can focus a little bit more on, the extracurriculars, whether that be research or gym or whatever. My eventual, training and career path, I hope to go into advanced heart failure and transplant. So that would be another year fellowship after 3 years of general cardiology fellowship, and then stay in academics and be faculty somewhere. And really, the rest of it is just continue training, kind of pushing the envelope, seeing what I can do in the gym, whether it's like lifting or benchmark workouts, or the CrossFit Open is around the corner. So last year I was in the quarterfinals, so we'll see how that goes. Yeah, I mean, I guess like it's just like a lot of exciting stuff. It's really a pleasure to work with like really bright minds. Your guys' insights on some of these, and the questions that you ask are really important questions in terms of like, how can you help patients? How can we help ourselves? And really, because you need to take care of yourself in order to help others. It's kind of like that, like, you need to put the mask on the plane before putting it on someone else analogy.
Yeah. Well, hey, Alex, man, I also want to say thank you, man. It's been a pleasure getting to know you. I'm glad you could have come on here. So truly appreciate that. I know we didn't get to delve too much into MRF, but we're going to link that article in the show notes that you have, man. Because, dude, if I did something like that, I probably would have torn like all the muscles in my body, maybe my tendon. That's just absolutely insane that you were able to do that. So
it's all right.
We'll
know me, I got you.
Notes.
I'll fix you up.
Yeah.
Yeah,
that's right. We got all.
That was honestly that was a huge thing, because I was basically doing MRF, and I was like, I can't remember what rotation I was on, but I was sitting there and I would just, because the gym was closed and this was COVID.
Yeah.
So I would literally do MRF, and then I would go and I would sit and analyze the data, and then I would write these WHOOP grants, and I was designing this study. So like it was pivotal. And honestly, when I was doing it, it was like an hour a day. The whole time I was doing it alone. So the whole time I remember just running and being like, oh man, what other ideas like do we have for this? So like it's actually like pretty instrumental in why I ended up doing this, because it was just like me and my thoughts, and I was just like, man, this could be big. I hope that like, we can do it, and we did it. So it's solid.
Yeah. That's awesome, man. It's big. It was. And, also in the show notes, I'll put all your social so people know where to find you. I know you're big on Twitter as well with academic stuff. So 2 last questions for you. I don't think any conversation is fully over unless you ask Dr. Alex Hajduczok about the Bills. So, almost made it this year, but what are your hopes next year for Josh Allen and the crew, man?
Woo, that's a great question.
What are you thinking?
Well, so they opened up as a plus 750 to win the Super Bowl next year, and I believe that they were tied with the Chiefs for that. So they're kind of like co-favorites with the Chiefs. So I would say, statistically speaking, according to Las Vegas, they're up there. Obviously, like, I walk into every year saying that they're going to win the Super Bowl, but we have yet to get that point. But I do believe they were truly knocking on the door.
100%.
Years of being a Bills fan and a Sabres fan. I mean, we had a 17-year drought of no playoffs for the Bills, and the Sabres are still in the doldrums. But the Bills are basically, talking about improvement of wellness. Like, the whole city of Buffalo is happier when and honestly, Allen you can't argue. Like, he's obviously the real deal. And he's like a great guy. Like, he's raised a ton of money for like Buffalo Children's Hospital and stuff like that. And so, like, happy to have him as the figurehead of the team. I mean, I gotta stay optimistic and say that 2023 is our year. But that's why they play the games.
Yeah.
I will hopefully be celebrating a Super Bowl at some point in my life.
Oh yeah, no, I think that'll most definitely happen with the Bills, man. I think Casey's on the way down. I don't think Joe Burrow makes another Super Bowl. Hot take right there. So I really do think it's Bills to get there. Last question for you that we ask all our guests is how do we put the health back in healthcare?
Oh man, this could have been like another hour on the podcast. Yeah. Honestly, I feel like we've kind of been talking about this premise indirectly the whole time without you answering that question. I think that really it's patient first, and that's the key to everything. And I think that everything else revolves around that. And when you put aside all the the BS that we deal with, all of the administrative tasks, all of the scheduling difficulties, or getting off for weddings, and all these things that stress us out. And you kind of like realize like why you're there in the first place. When you're a little kid and you decided you want to be a doctor, or maybe that path was different, and you figured it out somewhere along the way. I think really leaning into that reason for taking care of people. It's one of the most humbling experience to fix someone. I'm sure you guys have experienced plenty of that, and it honestly is like a tearjerker. You're sometimes like, I can't believe that my job or my life is devoted to being able to help these people. It's such an honor, and you go through a lot of training, and it can be difficult at times, but it's all worth it in the end. To see those smiles on those people's faces. And, watching them walk out of the hospital and things like that, or, fixing them up in clinic and making a difference. Like that's how you put the health in healthcare, like just breaking it down to the fundamentals, always going back to those fundamentals of why we did this in the first place.
Love it. Thanks, Alex.
Thanks, guys.
Well, the future is here, especially when we talk about wearables, technology in healthcare. I mean, there is such a boom happening right now in terms of this integration between using technology and using it to aid different metrics so that we can provide better healthcare to patients. Now, if you found this episode fascinating, you can definitely check out the show notes, take a look at Alex's Twitter. He posts a lot about the data in the cardiology world, but also about his personal journey and how he's using Whoop to optimize his fitness. And again, if you want to support the efforts with this ongoing battle in Ukraine, definitely check out the 2 links below where you can check out Dr. Hajduczok's story, but also support the GoFundMe page that he has set up. And of course, if you've enjoyed this series, the last 3 episodes here have been about cardiology. Please let us know. You can send us an email at medredefined@gmail.com, and be sure to share this episode with anyone who you think could benefit from it. And be sure to subscribe as well so that you can stay on top of our episodes weekly. All right, and now time for the medical disclaimer. Anything in this podcast is for educational purposes only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. And we will see you next week with a lessons learned.